Okay, Jerome. You can start.
Can start?
Okay. We start now?
Yes, yes.
Okay.
Please,
So
please
okay, just to introduce Xavier Fallieres, you of course everybody knows him now. So he will give another lecture about anesthesia. I think it's very important for you to have this lecture and how to do anesthesia in all situations. So thank you, Xavier, to participate and to help all Myanmar people giving this lecture. Thank you, Xavier. You can start.
Okay. Thank you, Jerome. So, Megalava, good morning. Today I'm going to share this presentation. We have a lot to do. We are going to speak about nerve blocks, and I think it's necessary when you have an ultrasound machine to know how it works, the basic things you have to know. Then we speak about security in local regional anesthesia, and we will say some words about adjuvants you may be used if you have them. It could be very interesting. Then we will go on very practical things about block for the upper limb, and we'll see how far we can go today. And then we will go on next time on the 27th of February. So you need to know that ultrasound is a form of mechanical energy transmitted as a pressure wave through a given medium due to the vibration of molecules. We don't hear the ultrasounds. Some animals can hear them. We don't. It's above the 20 kilohertz. What is important to know that what we see in our screen is what will be back in the probe and not directly what we see in the tissues. So the echogenicity, what you have to know of the tissue, it refers to the ability to reflect or transmit ultrasound waves. Whenever there is an interface of structures with different echogenicities, a visible difference in contrast will appear on the screen, so you have to know it. And based on the echogenicity, a structure can be characterized as hypo, hyper, or anechoic on the screen. And we are, in this context from today, looking for nerves. So the nerve, they will appear of very different ways, sometimes very unpredictable. Mostly the proximal nerves are hypo and the distal nerves are hyperechoic, but it's not always. So it's very, very variable, depending on the proximity to the neural action. When a nerve is hypoanechoic, they look like blood vessels, but they are neither collapsible nor pulsatile. When you are giving blocks with ultrasound, the ultrasound-guided regional anesthesia, you have to know 10 things very important. You have to visualize key landmark structure. It's not because you're giving blocks with an ultrasound that you don't need to know your anatomy. You have to know the structure, the blood vessels, bone, fascia, muscles that you see. You have to identify the plexus of the nerve in short axis, sometimes in long axis, but we'll see the definitions later. So then you confirm the normal anatomy and recognize variations. Also, you have to know it. You plan the needle approach before giving the block to avoid unnecessary trauma or blood vessel. Maintain aseptic technique as much as you can. For a single shot, you don't need to do a lot. As an intramuscular, you don't need a lot of asepsia. You need to stay clean. Please follow the needle real time, certainly for the supraclavicular block. Consider always a second confirmation technique if you have it. Use hydrolocalization. We will see it. please, when you have only 20 milliliter lidocaine to give for a block, and if you spend 50 milliliter to try to localize the nerves, then you have nothing over. So use normal saline when you begin to localize where is your needle. And then you follow the correct spread of the local anesthetic. And please maintain minimum safety guidelines for the resuscitation. Perform aspiration tests and try to monitor your patient with, I would say, with a saturation monitoring. And there are some levels of difficulties in block. The deep blocks, you will have a degradation of the ultrasound, and the needle, it will be difficult to see where you want to go. And less in Myanmar, but we have this in our countries. We are more and more confronted with patients with a BMI above 35, 40, 45. We don't care anymore, but blocks are challenging. And then you have all the blocks near little structure. It can be very challenging, small nerve. And I won't speak today about the catheter-based techniques. What is very important to know, what are the definition when you will read it in books or of the New York Association of Regional Anesthesia, what is the axis and what is plane. You will see the terms of axis. Axis is the relationship between the probe and the target. Short axis, mostly we use for nerve block, the short axis. The ultrasound beam contact the structure of interest in the transverse direction, creating a cross-sectional image. The long axis is not very used in regional anesthesia, only for the sciatic nerve. It can be useful in the gluteal approach. Sorry, I have a cat home, a little bit difficult. The ultrasound beam in the long axis, so we'll follow the structure along. Sorry. And then in plane or out of plane, the needle approaches the structure in the length of perpendicular to the beam. Mostly, the blocks are performed in plane. There are big indication, large indication out of plane, for instance, for interscalene block. Sorry. Then you have to select the transducer. Sorry, I come back to take some water.
Okay, we wait a little bit now for Xavier, and so
I own some the kitchen is right next to here.
yes, it's okay, Xavier. Now,
yeah, it's okay. Sorry, I have some problem.
We can wait. We can wait 2 minutes if you want, if you need. So we speak about.
Yeah. Oh,
it's okay.
Yeah, it's okay.
Okay, let's go.
Transducer selection.
Let's go.
You have to, when you have some different select transducer, please try to select the one you need. The area of interest, deep or superficial, the size of scanning window, and size of patient, sure. You can see here when you use a high definition probe, 812, now we have the 615, you don't go very deep, but you will have a very high definition of the structures, you will see. When you use medium, a 6 to 10, you will see less details, and when you use the low definition probe, the 2.5, the curvilinear probe, you will see very deep, but with a very low definition. Mostly all the machines now for us as anesthetists, we have 3 probes. The very, very high definition, mostly the 6 to 5 megahertz is wonderful. You can see almost everything. You can go up to 8 centimeter deep, and then to go up to 20 centimeter deep, you will use a curvilinear. And the curvilinear has also the advantage to reflect the needle in a curve line of curve form, so you will see the needle much better. Certainly when you have an angle above the 60 degrees. So you will see here the difference between the low frequency and high frequency. You have 2 points. If you use the low frequency probe, you will have a poor resolution. When you use a high frequency, you will see the real image and not an artifactual image. And please don't begin your block without testing with your finger, which is left side, right side of your screen. You will see here that the green point on the screen corresponds to the notch on the probe and not to the dot. This is the green point of your screen. So always check with your finger before giving your block. And don't do very difficult with the machine. You have a lot of machines, they have some preset for the nerve blocks. It's very easy. So you don't need to do a lot. You only have to correct 3 parameters. The gain will give you a dark, balanced, or bright image. So always try to have the best image for you. Don't go too dark, don't go too bright. The depth, and also you have to anticipate when you will inject your block, the depth can increase. So try to determine before giving your block what is your ideal depth. And then you have the frequency. You can adapt it for resolution, general, and penetration. Resolution is for very, very superficial blocks. General is for everything. And when you have to go deep, it's sometimes useful to use the penetration modus. The Doppler can be very useful to localize arteries. It's not red for artery and blue for venous. No. It's flow toward the transducer is red and away from transducer is blue. So it's very important when you need to localize vascular structures to use the Doppler on your machine. So please keep it very simple. We have preset. We need the depth, the gain, the frequency, and some color Doppler, and that's it. We are not radiologists, so we are very simple anesthetists, so it's what we need. Also, as I said at the beginning, please know your anatomy and have some basic idea of the sono anatomy. And when you give a block, please use pressure, alignment, rotation, tilt, and slide. You have to move your probe, and sometimes moving your probe will change the image, and you will see the nerves of other structures much better. And please learn hand-eye coordination and be efficient. Don't give a block with the screen at your back or to the left side, the right side. Please position everything. Also, the one who will help you to give the block have to stand next to you, not at the opposite side of the patient. And perhaps you will need a hand to modify some parameters on the machine. So, mostly at the beginning, sometimes experienced anesthetists, we have problem to visualize the needle. Because, as you can see, what you see on the screen is the reflection of the ultrasound going on the needle and going back on the probe. So more than 60 degrees, the image will get out of the probe. So I say, oh, I can't see my needle. Or you see only the shadow of the needle. So you can align, you can tilt, you can rotate, you can slide. You can use the heel maneuver. And then you will see your needle upright. No, go back. You will see your needle. That's a very important thing. And some machines, they have an artifact correction to see the needle. And when it's very, very difficult, use a curve or line, a probe, you will see your needle much easier. Only one move at one time. Don't do all movements at the same time, because then you don't know anymore what you're doing. So you move the ultrasound solution, the needle, to optimize the procedure and to visualize the tip of the needle. It is a dynamic process. You don't inject your local anesthetic till you can visualize the tip of the needle. And what I'm doing every day, I use hydro dissection with normal saline. And also in very difficult blocks, it will help you to see the needle. So about the equipment, it's now very simple. Use very, very clean environment with some alcohol. Don't forget that contact with alcohol directly with the probe can be bad for the probe. So you have to always wait that it's dry. Don't clean the probe with alcohol, please. You have to clean it with some soap. Don't use directly alcohol on the probe. You will destroy the probe. So needle, you need, mostly, I would say for me, you can give all the blocks with the 50 and the 80 millimeters needle. When you have block needles, it's much better because they are not so sharp. But if you don't have, you use a normal needle. Intramuscular needle. Screen preparation, I would say keep it clean. Chlorhexidine, alcohol, betadine, everything is good. And the probe cover, we were using a Tegaderm. They said that Tegaderm can be bad for the probe, but now we don't use anything. We used some sterile gel, and we give directly contact with the gel and the skin, and when we clean the probe, we have the best image. So that's a little bit about what you need to know for ultrasound guided and the machine. So it's very, very simple. You need 3 parameters, a Doppler, and you have to train and train and train to see your needle. Use hydrodissection when you don't know where you are, to localize your needle before you inject your local anesthetic. But it can also be very unsafe, and certainly in your circumstances, you don't have so much. If you have an acute local anesthetic intoxication, you will have a big problem. So keep it safe, and you won't have any problem. What can go wrong? The wrong patient, the wrong side. Be very careful. Don't say it never happens. It happens. And certainly when you change the position of the patient. So check the side before. Wrong medication, please do a double check with someone of what you put in your syringe. Check and recheck. Think about the endothelial block, certainly for the phrenic nerve interscalene block, toxicity, and then we will have very shortly about the mechanical and the chemical trauma, and eventually bleeding. Respect the max doses. Resorption in blood, for instance, for a transversal abdominal plane block, the resorption is very high. And then you have the epidural and the local regional and the infiltration. It means that infiltration you may give a lot, won't happen anything. Then you have the risk of a higher toxicity in elderly, heart failure, blood loss, liver failure, hyperkalemia, and acidosis. So try to reduce the dose of 20%, and when you need volume, you reduce your concentration. And in children, please use the lower limit for toxic doses. Avoid the combination. I know in Myanmar you're mixing since many, many years. I'm working there now, so now 12 years, always combining the bupi and the Lido. I have colleagues doing it. There is not any evidence-based to say it works better. It has no real advantages. It will give you a block, that's it. You won't have the advantage of a short onset time and a long working block when you're mixing a short acting and a long acting. And have a protocol, please, very short protocol, if you have for the treatment of the systemic local anesthetic toxicity, you look at the ASRA recommendations. So I would say yesterday I was looking at the last literature and it's very clear about the maximum recommended doses and the duration of local anesthetics. The actual recommendations are not based on any evidence. It is now 50 years, then we hear that we may give maximum 3 or 5 milligram per milliliter per kg. Lido, it's not proven. We don't know. It's certainly much higher than the official recommended doses. We are using now many years huge doses of lidocaine IV up to 24 hours, 1.5 milligram per kilo per hour. We haven't seen any intoxication. So it means we may give much more than one we think. It's only how you give it, how fast you inject it, how the intravascular diffusion of your local anesthetic, which can be dangerous. Just officially, I would say the Lido in block is max 5 milligram per kilo, and you use adrenaline when you have it, epinephrine, and you can go up to 7 or 8 milligram kilo, won't happen anything. The bupi is something else. 2 milligram kg with epinephrine, 3 milligram kg. If you have some intoxication with the lidocaine, I would say it will be okay with the patient. When you have it with bupivacaine, you have a huge problem. So be vigilant, you monitor your patient. I know you don't have ECG everywhere. You have saturation. Please try to measure the heart frequency, the heartbeat and the blood pressure. You communicate with your patient. You ask your patient how it's going. Limit the doses depending on the site of injection. Be very careful with hypercapnia, advanced age, poor cardiac function, patient with heart disease, and also abnormally low plasma protein concentration, certainly in elderly and underfood patients. Aspirate regularly every 5 milliliter. You control if you don't get any blood back in your syringe. You go slowly. You are not in a hurry. You inject slowly and you observe and you monitor your patient up to 30 minutes. After 30 minutes, the journey is safe. You can go. If you don't have monitoring after 30 minutes, it's not a problem. And when you have ultrasound, you control the diffusion. So the local anesthetics toxicity, it can take different forms. It's not very easy sometimes to see it. Mostly you will have a central nervous system excitation, agitation, confusion. That's mostly what's happening. Drowsiness, the patient will say, I don't feel good. You have a metallic taste in the mouth, paresthesia, diplopia. These are signs that mostly will tell you, oh, I have a typical local anesthetics toxicity, but it's not always. You are also a progressive hypotension, bradycardia, and it can lead to a systole or a severe cardiovascular problem. It's a high toxicity. Ventricular ectopy, multiform ventricular tachycardia, you can see it also and the ventricular fibrillation. Mostly when you have this with the bupivacaine, unless you have intralipid, it will be deadly for the patient. So if you can have, I know your situation in Myanmar, that's why I said be careful when you give your blocks. You need intralipid, but it's only if you have it, you need to know how much you need to give. But you have also to resuscitate your patient, to have excision, external electric shock. You need to reanimate your patient and to treat all independent factors and epinephrine in case of asystole. So this airway management, seizure suppression, cardiopulmonary resuscitation, and please, yeah, I know in your condition it's totally impossible mostly, but if you have some cardiopulmonary bypass capability, it could be good for the patient. This you have to know when you have intralipid and bolus from 1.5 milliliter kg intravenously in 1 minute, and then you give a continuous infusion of 0.25 milliliter per kilo per minute, 500 milliliter in 30 minutes, and you repeat boluses every 5 minutes for persistent cardiovascular collapse. Double the infusion rate if blood pressure returns but remain low. Continue infusion for a minimum 30 minutes. So we have no controlled trials, but it will save a life. And when we speak about security, this was now the worst case scenario of deadly intoxication and what you have to do, potentially deadly. But now I would like to speak more about the security of the mechanical and chemical trauma when you give the block. You will see your needle can arrive in some very, very fragile structures. You can, giving a block, damage the nerve directly, nerve laceration, nerve damages, exposure to local anesthetic, and yeah, theoretically, adding adrenaline can be a risk of ischemia. I would say you need high doses, please use adrenaline. And then the question, is it harmful to inject intraneural? No, if you stay extravascular. If you have minimal doses to give, it's perhaps better to give just intraneural extravascular than to give just around and far from the nerve. You will need much less volume to have a good block. But how to prevent the intravascular injection? That's the most important to know. Ultrasound, you will see the nerves. You will lower the dose of local anesthetics, as we said, but you won't make any distinction between intra and extravascular. The neurostimulation, you mostly don't have it. I provided some years ago, but don't worry, it won't make any distinction between the extra and the intraneural. It can be useful for inconclusive ultrasound image only. The pressure monitoring is very, very important. An intraneural extravascular, the pressure will stay under the 11 psi, and when you are intravascular, you will have a high pressure and also a lot of pain. So it's very easy. You don't need very, very expensive material. You have to know you take a 20 milliliter syringe, you fill it with air, you put your finger and you press from 20 to 15. This gives you the idea of the maximal pressure you may admit when you give a block. Our nurses, they're trained, they say, oh, it's too hard, I stop. And as I said, I am totally adept of the hydrodissection, because before you give your local anesthetic with normal saline, you can localize where you are. So first use a normal saline, when the needle is correctly positioned, then you can inject your local anesthetic. And if you are intraneural, intravesicular, you can't damage a nerve with normal saline. So respect the max doses. Once again, if you give very slowly, if you use adrenaline with lidocaine, you can go up to 7-8 milligram kg. It won't happen anything. But when you need the very high volume, please lower your concentration. It will give you also a very good block. Try, when you can, have a protocol local anesthetics intoxication. The intravesicular injection, then that will cause damages. No stimulator, it can't prevent anything. We don't use it anymore, only in very, very deep blocks. Pressure monitoring, please use the syringe test to feel what is above 15 psi. Yeah, for the anticoagulation, you don't have any guidelines. Mostly for a single short block, not a deep block, we don't have any contraindication anymore for anticoagulation. We give blocks in all circumstances. Only for the very deep blocks, we have to follow some safety guidelines. Certainly, patient using anti-vitamin K and anti-10A. Be safe and objective. Then I will tell you some words very quickly about adjuvants, because if you have some of them, it can be very interesting to use them to prolong the effect of the blocks. But yeah, it will give you a longer lasting block. You will reduce the total dose of local anesthetic, reduce the concentration, which can be very useful for you when you need a huge amount of local anesthetic. And now I'm very busy with a big study about the rebound pain, but that's not a subject for today. So what do we know? Adrenaline, epinephrine, the alpha-2 agonists, the opioids, DEXA, and the others. The adrenaline is a very, very big debate. I have a colleague, she doesn't want to hear about it. It's very dangerous. No, it's not dangerous. It's okay. You need large volume, so I would say use adrenaline in your mix of 1 up to 100,000. It means 0.1 milligram for 10 ml. You will decrease the Cmax of the bupi, lido, MAPI, not for the ROPI. You will detect intravascular injection. There are some neurotoxicity demonstrated in animals, but not in people, except for diabetic polyvascular patients. But once again, we are not in these very subtle differences. So you need high volume. When you have adrenaline, use adrenaline with your lidocaine. And then, yeah, I remember many, many years ago, I brought clonidine to Myanmar because clonidine is very interesting in anesthesia and certainly in blocks. It prolonged the effect of the block for many hours. And hemodynamically, it will stay, if you stay at low doses, up to 75 mic, it won't happen anything. About the dexmedetomidine, I don't think you have it. It works. It works, definitely. The dexamethasone is a very long debate. I took 2-3 weeks ago the last literature about it. I was a big adept of dexamethasone in blocks, but I would say definitely it doesn't have any advantages compared to intravenous. So same effect. I was before saying always you have to give it 50-50. But no, it's not neurotoxic, but IV is the same effect as perineural. What has changed are the doses. We give now 12 to 20 milligram dexamethasone IV, which is much higher than the 4 to 8 milligrams we were giving before. And it works definitely very good as painkiller, and it also certainly avoid rebound pain after blocks. opiates. Opiates, it doesn't work. The only one working in block is the buprenorphine 0.3 milligram. A lot of side effects, but if you need to prolong dramatically up to 12-hour your blocks, use 0.3 milligram buprenorphine in your blocks. Magnesium is very simple. It works, it prolongs up to 10 hours. Your block, we use mostly 400 to 600 milligram in our blocks or in our mix. It shortens the onset, it prolongs the effect of local anesthetic. It's not toxic on nerve. It's now demonstrated. Don't giving intrathecal, but giving in peripheral blocks, it works. Then we have the rest. I would say the ketamine, please don't do it. There is only one study and hallucination, nausea. It doesn't have any advantage to give ketamine. The neostigmine, it was many, many years ago. It has been said that neostigmine perhaps could have an effect on the blocks. No, it doesn't work. Midazolam, yeah, it works, definitely, but it's toxic. So it has been demonstrating the neurotoxicity is known, is published, so please don't use. And the bicarbonate is from a very young time. We were using some bicarbonate with the idea of working on the PK of the mix will give a better onset time and longer blocks. No. But I will speak about the Wallen technique in the next hour. Very interesting for you in some very remote areas to look at to use Wallen technique. Its use, it's combined with adrenaline. It will lower the acidity and lower the pain at injection when you are using lidocaine with adrenaline. So I would say adrenaline, okay, use it. When you have clonidine, use it. When you have dexamethasone, give 16, 20 milligram IV. Opioids, when you have buprenorphine, use 0.3 milligram in your blocks. When you have magnesium, use it in your blocks. The other one, only the bicarbonate in the Wallen technique. The rest don't use. So the adjuvants, you're for, you're against. I am totally pro adjuvants in blocks, and that's what you may use. Okay, this was the first thing. Then we go on with the second lecture, if everybody is okay, because now we are going to have in two parts from today, and then we will go on February the 27th about speaking about the different nerve blocks. And today we are going to speak about the upper limb, brachial plexus and nerve blocks. What I wanted to do today is not to speak about the high technique things, because these you don't have. I want to go back to the very, very practical things. And the ones on Facebook who knows Dr. Xavier from Liverpool, from India, working in Liverpool, you can all time contact Xavier. He will send you information. It gives very big lessons in India about how to give a block when you have only a needle. I spoke Xavier last week. I said that, yeah, you may contact him every time you need some information. It's on Facebook of the group, the Anesthetist. So the anatomy, very simple. We have the three trunks. We have the roots, the trunks, the division, the cords, and the branches. It's only to give you an idea if you need to be very, very subtle, giving some differentiated blocks. You know that the sensibility is very different depending on the nerves. This you have to know for the hand, certainly. Then we have all the myotomes for the muscles, and the sclerotomes for the bones. But the conclusion in the present situation in Myanmar, I would say it's not very important. It's not relevant. It's not your problem, actually. The only thing you need is a good block, complete block. You don't need to know, I need more the ulnar or the radial or the median nerve or the musculocutaneous nerve. No, it doesn't matter. Keep it simple and stupid. Give a total, complete, good block and keep it safe. Sorry. We are going to speak of the four levels, of the brachial plexus blockade you can give, the interscalene, the supra and the infraclavicular blocks, and the axillary block. Please give your block depending on the surgery and what you want to reach. Don't give an interscalene block for a hand surgery. It's totally useless. So the interscalene block is very indicated for shoulder and proximal upper arm. Very good block. Landmarks without neurostimulator, we can see how we can give it, and ultrasound guided. When you give a landmarks, you will look for paresthesia shock in the shoulder, neurostimulation, shoulder contraction when you have it. All other signs in neurostimulation are not good. Then when you give the interscalene block with ultrasound out of in plane, I am totally, sorry, I'll come back here. For out of plane, it's the best block you can give is out of plane. I will explain you why. But be very conscious when you give an interscalene block. Almost 100% will give anesthesia of the phrenicus nerve, recurrence nerve, 75%, cervical sympathicus with a low blood pressure. And then we can have, certainly when you're giving this block blind, spinal arterial blockade. So be aware that it can be dangerous. Severe pulmonary dysfunction can be a huge problem in when you give an interscalene block. So the landmarks are very, very easy, certainly in normal weight patient. You will have the clavicle, the posterior border of the clavicular head of the sternocleidomastoid muscle, and the cross point at the external jugular vein. It will be the place to give your block. Very important. So you will pave with your fingers. You will feel the groove between the anterior and the middle scalene muscle. It's very easy to feel it. So what you can do to for the landmarks is to ask the patient to face slightly away from the side to be blocked. It tenses the sternocleidomastoid muscle, and to leave the head of the table while facing away. You can identify much easier the posterior border of the clavicular head. The technique, the finger or the palpating hand should be gently pressed between the anterior and the middle scalene muscles to reduce the distance between the skin and the brachial plexus. It's never, never deep. Don't go deep. If you go deep, you can finish spinal or epidural. That could be dangerous. So mostly 1.5, 2 centimeter, half inch is your in. So you take a short needle with a short bevel, and you insert between your fingers at the level of C6. When you have the paresthesia of an electric shock in the shoulder, it indicates that the needle is in the good position. So because you are without ultrasound, you need some more volume. I would say if you need a good block, inject, I would say 20-30 milliliter of your local anesthetic. The way you have to do it. It's very easy. it can bring a lot. When you do it with ultrasound guided, try to put your needle at the C5, C6 level. Here you can see the anterior and the median scalene, and you see here the stoplight, C5, C6, C7. So what I'm doing myself, because don't forget that the phrenic nerve is here, you see here above, I always give it out of plane and I position my needle at the C5, C6 level. Then you have the very well-known in Myanmar supraclavicular block. And the people of my generation in Myanmar and some younger anesthetists, but not too young, they know precisely how to give a supraclavicular block with an intramuscular needle. So, indication, upper arm, sometimes shoulder, and elbow and forearm and hand. Eventually, it will give you a good block. It has always been said, due to very high risk of pneumothorax, this block is now not anymore recommended without echography, but it's a very useful block. And some of my colleagues, once again, from Myanmar, I think about Tim Min from the Orthopedic Surgery Center in Yangon, and other ones, they can give it so good without any echography or ultrasound. They need an intramuscular needle and they have it within no time. So the main landmarks for this block is the lateral insertion of the sternocleidomastoid muscle in the clavicle itself, and the patient midline. It's very easy to identify, and the paresthesia in the hand and the fingers will indicate the good position of the needle. This is here how to perform the block. Don't go deep. If you don't have it, be aware of the depth of the needle, because you can create a pneumothorax. Surely, when you have an ultrasound machine, it's a very easy block. You can see very easily, and I would say this block perform with ultrasound guided. Please follow your needle real time. Don't follow the shadow of your needle. The shadow of your needle, you are 1 or 2 centimeters further with your needle, so you're in the long bit before you know it. I would say single injection of multiple injection. We give mostly in 3 times. We begin mostly here, the difficult corner, very close to the pleura, because there you have the nerves going to the hand and the C81 branches. Then we go up, and then we go in the middle. It will give you, with low volume, 15 milliliter, you will have a perfect block. If you want a single injection only in the middle, give more volume and you will normally get everything. My recommendation is, please do it in 3 times. The infraclavicular block is less used than the other ones. I would say it's a very useful block. I will describe here the way that my friend and colleague Dr. Gartner from France described many years ago. It's very good for elbow surgery, forearm and hand. It gives a best consistent block of the neuromusculocutaneous and the nerve axillaris compared to the axillary approach. For the tourniquet, don't use the vertical mid-clavicular approach. Use the paracoracoid approach as described here. 2 centimeter under the coracoid and 1 centimeter extend to the deltoid point. Here you will go perpendicular, and after perhaps 1, 2, 3 centimeter, patient will feel some paresthesia in the hand, and then you can inject. Once again, it's a high volume block. Certainly when you don't perform it with ultrasound, 30, 40 milliliters are enough, or necessary and enough to get a good block. Ultrasound guided, I would say it's a difficult block. It's not so easy, and we don't perform it so much, sometimes as a rescue block. And now I would say, yeah, ultrasound is not very easy. It was a very popular blocks when we were giving blocks with the neurostimulator, but I would say ultrasound guided, the very sharp angle with between the needle and the probe makes it very difficult to localize the needle. I would say, okay, no real interest. It's interesting for you, as I show you just now, is the landmarks technique. And the very popular axillary block for education for the forearm and the hand, safe, easy, chance of success 60 to 100%. Landmarks, I will tell you much more about the very old-fashioned transarterial way to give an axillary block, ultrasound guided. Don't forget in this block that the musculocutaneous is always separate of the rest of the nerves. It's outside the neurovascular sheath. And there are a lot of anatomical variations. It's very inconsistent in patient. You will see that the median, radial, and ulnar nerves, or the distribution of the 3 nerves, is very inconsistent. What is always consistent is that the musculocutaneous is always outside the nerve sheath. The transarterial technique. So it's very easy. You can palpate the artery. So the transarterial technique is a very simple technique that you may use when you don't have anything than a syringe and a needle. So the axillary artery is palpated, stabilizing using 2 fingers palpation technique. The needle is advanced toward the pulse of the axillary artery. Yeah, you will see bright red arterial blood. It will be aspirated. So you advance your needle deeper, still you don't have blood anymore. You can't aspirate blood, you test really, and then you give the half of the volume, mostly 20 ml, injected behind the posterior wall. Then you come back, you aspirate blood again, then you come back till you don't aspirate blood anymore, and you give the other half, you gain the 20 milliliter. So it works very good. You have to be careful with the aspiration tests. You give an oblique angle, it's better. It reduces the risk of making the injection behind the artery muscularly, and it improves the spread of the local anesthetic. It's a high volume block, 2 times 20 milliliter local anesthetic. I'm going to correct it now. Could be necessary here. Sorry, I changed here 2 times for your better comprehension. Sorry, it's 2 times 20 milliliter. Anesthesia of the musculocutaneous nerve, certainly you will have a diffusion. It's always uncertain. When you have the ultrasound, it's much easier because you will see the artery, you will see all the nerves, and once again, you see here that the musculocutaneous is very far away from the others. you have to perform mostly multi-injection, musculocutaneous above and under and at the backside of the artery. Mostly you will have a complete block. It's not very necessary to localize each nerve very precisely. If you inject 1, 2, 3 times around the artery and you take the musculocutaneous separately, you will have a wonderful block with 20 to 30 ml. Now, very important to speak about the distal rescue blocks with, or perhaps for you, not really rescue blocks, but very useful blocks for hand surgery. The musculocutaneous blockade, you won't have the musculocutaneous blockade in these cases, so please only for hand surgery. So you have to know some anatomy and some distribution of the 3 nerves, median, radial, and ulnar in this case. Ultrasound guided, it's quite easy. The radial nerve, you can perform it at the elbow here, above and here. Very distally, you will see the radial artery and you will have the radial nerve here. You see it here. Very distal blocks. And when you are at the elbow, you will see it here. Then the median nerve at the elbow, near the brachial artery, you will have the median nerve, but very classical. You can have it at the forearm and going also very distal. And we had at the beginning about the hyper and the hypoechogenicity of nerve. The median nerve at the forearm is hyperechoic, and when you go down to the wrist, it will become hypo. And the ulnar nerve is the same. You see the humerus between the triceps and biceps and triceps. You will see the ulnar nerve, and you can have it very, very easily at the wrist. Near the ulnar artery, you will see the ulnar nerve. So if you give 3 to 5 milliliter in each nerve, you will have a wonderful block. But without ultrasound, I would say a very old and well-known technique is the ulnar nerve at the elbow. The ulnar nerve at the elbow, it's very superficial, it's very easy, you feel it yourself, and you can give yourself a shock on it, so you know where it goes. At this level, it's very easy to give some local anesthetic. You will have a wonderful block. You identify the ulnar groove with a short needle, 1 centimeter proximal to the epicondylus, and doubly distally. So the patient will find paresthesia to the little finger or a motor response with a finger flexion, thumb abduction, and or ulnar deviation of the wrist. Then you are good, and you can inject only 3 milliliter local anesthetic will be enough to have a wonderful block of the ulnar nerve. But much more important to know, when you don't have anything and you need to give a good block for hand surgery, you can perform a blind infiltration at the both lateral side of the radial artery, ulnar artery, there, and then for the median nerve, you will give some local anesthetic between the flexor carpi radialis and the flexor pulmonaris longus, and then here a lot of surgeons giving self-anesthesia for carpal tunnel syndrome. They know perfectly how to perform this block. It's very useful. So we can have a very complete anesthesia of the hand using this blind technique. So if you're okay, I would like to go on with the Walland technique. The Walland technique is Walland for wide awake, local anesthesia, no tourniquet. We know it's becoming very popular, and I think that we anesthetists in our country, we will lose the hand surgery, the small hand surgery as peritoneal surgery. It won't be at the OT anymore within, I think, 2 years. It's always, it began in a lot of hospitals. Patients are proposed on wide awake local anesthesia, no tourniquet. They don't need any plexus nerve blocks, and they go directly home after the intervention. For you in Myanmar, I think it's very important to know that you can use this technique, because when you have nothing for hand surgery, and you have, I think, a lot, it's very important. Now, it's popular, and it's more and more used from very simple to less simple surgery. Walland uses a combination of local anesthetic and epinephrine to induce anesthesia and hemostasis in the area of the surgical procedure in order to allow surgeries to be done without tourniquet. Very, very useful. So epinephrine is a vasoconstrictor. We spoke about it for blocks. It reduces the blood flow at the surgical site. It gave a bloodless effect and a good visualization for the surgeon to operate. The skin at the hand is becoming totally pale. It provides a chemical tourniquet and eliminate pain from a traditional arm tourniquet. So, very interesting. But it's performed with short-acting local anesthetic, and there are some studies using some adjuvants, but till now, it doesn't offer any postoperative analgesia. But okay, it's very interesting. To perform Walland, you inject 1% lidocaine with adrenaline of 1/100,000 into the plane area of incision of the surgical dissection. It provides up to 4 hours of local anesthesia and vasoconstriction, so you can operate for 3 hours. Often, I would say if you need to add 1 milliliter, 8.4% bicarbonates to lower the acidity and the discomfort of the injection. Bupi, Ropi are not being used in this indication of Walland because they can be very toxic. What you need to know, you may not be in a hurry. It means you have to plan and to wait real 30 minutes after injection before performing surgery to get a white hand. If you don't wait enough, it will blood, and then you will have a very unhappy surgeon. There is a lot of debate, many years, about the safety of local epinephrine adrenaline injection in the hand. Some said you need rescue phentolamine if you have a white finger after some hours. It has never been seen, so it's totally safe. And now they've performed millions of Walland technique on hand surgery or also foot surgery without any problem. You can use 7 milligram kg of 150 cc for a 70 kg patient. You can, for instance, also for foot surgery, it's becoming also popular. You can use up to 100 milliliter Lido if you lower the concentration to 0.5%. So keep in mind, try it. We began in a hospital and with high satisfaction also from patients. The Walland technique is very, very useful, certainly for you. And back to the old technique, to my time I was beginning anesthesia, we were giving the beer block, the intravenous regional block. And it's totally back, and certainly for you, if you have a double tourniquet, it can be very, very interesting because it's totally simple and it's great and it works. What you need is a hand bubble, but a double. I see here, sorry. I see that was not. When I did it, you need a double pneumatic tourniquet system to use it. You need intravenous regional anesthesia using anesthetic mostly. Commonly, you use Lido 0.5%. It works up to 1 hour. It's very good for soft tissue operation, for ganglion, for small, for wounds, for carpal tunnel release, for Dupuytren contracture surgery, a reduction of fractures. It has very good indication. Once again, compared to warrant, it works up to 1 hour. After 1 hour, the effect will disappear because you don't have a tourniquet working really 100%. So you will have a resorption of the lidocaine. So what you have to know when you're performing a beer block is the necessity of exsanguinating the extremity, and you need an Esmach bandage, and it can be potentially painful for the patient. So, okay. It can be useful when you use it for trauma. It can be painful for the patient. So equipment, you need a local anesthetic agent at lidocaine. I would say for 40-50 ml, use 0.5%. You need 2 pneumatic tourniquets of a double one, 2 venous accesses, one for the operated side and one for the other side. If you need to inject rescue medication or some sedation or something else. Use standard minimal monitoring to keep it safe. You need some resuscitation equipment. I would say I performed local intravenous regional anesthesia many years. I haven't seen any problem. The Esmach bandage, skin preparation, and a 30-50 Luerlock syringe. So that's here the way to do it. Once again, it's a very simple technique. So you prepare your needle, you perform the exsanguination with the Esmach bandage, then you inject the local anesthetic. And after some minutes, after mostly 20 minutes, the patient will feel some discomfort with the proximal tourniquet, and then you can inversize. And inversizing, it means that you inflate the distal curve and deflate the proximal curve. It will give a better comfort for the patient. It won't feel anymore the tourniquet. So I would say this is a very, very useful technique. Keeping in mind, it was very popular up to now, I would say 20 years ago, now perhaps 15 years ago, but it's something in your conditions now in Myanmar. If you have a double tourniquet of 2 tourniquets, please use it. It works on upper and lower limb. It gives up to 1 hour anesthesia. You can use some adjuvants because the big disadvantages of these techniques, when you stop, it stops. The pain will be back within no time. So it's a rescue method. It has been very popular and it can be very useful for you. So I think we have done a lot here because we will have now some discussion. Next time, we will speak about the lower limb, also very important for you, all the plexus and nerve blocks, and we will speak about what you can do with interfacial plane blocks.
Thank you, Xavier, for this lecture. So